Chapter 13, the Respiratory System. Here are the primary objectives for this chapter. I'll stop a second so you can pause the video and read these yourself if you want to. Okay. Section 13.1, the respiratory system provides us with essential gas exchange. So the functions of the respiratory system are that it filters the incoming air, helps to maintain blood pH, helps control fluid and thermal homeostasis, and also allows us to produce sound. The respiratory system is divided into two parts. The upper respiratory tract, which primarily conditions air as it enters the body, and the lower respiratory tract, which allows oxygen to enter the blood and waste gases to leave it. Here's a diagram of the respiratory tract divided into the upper and lower. So in the upper respiratory tract we have the nose, the nasal cavity, the oral cavity, and the larynx. Whereas in the lower respiratory tract there's the trachea, the bronchi, the lungs, and the bronchial tree, which just breaks off of the bronchi. Now we're going to talk about the structures of the upper respiratory tract, and these are the nose, the pharynx, and the larynx. Now the epithelium in the nasal conchae and nasopharynx in the nose is pseudostratified ciliated columnar epithelium, and there aren't too many examples of this type of tissue in the body. But anyway, this tissue is covered in mucus and bathed in tears. The main purpose of the nasal cavity is to warm, filter, and moisten incoming air. The hairs of the nose work to filter large particles, while mucus acts to filter out smaller particles. And we need this so these particles don't end up in the lower respiratory tract. The large blood supply of the nose serves to warm and moisten the air. The nose also houses the chemosensory receptors, which are responsible for our sense of smell. The septum of the nose is a plate of hyaline cartilage, which divides the nose into the two nostrils, or nares. And sometimes the septum can be displaced or not line up properly, and this condition is called a deviated septum. And if a deviated septum is significant enough to cause difficulty breathing or speaking, it may be necessary to surgically correct the problem. And now we're going to also talk about the other two structures of the upper respiratory system, the pharynx and the larynx. Here's a diagram of the various parts of the upper respiratory tract, and in this diagram they actually have the pharynx divided into its three component parts: the nasopharynx, the oropharynx, and the laryngopharynx. And also the larynx is labeled, and so are the parts of the nose. But anyway, another thing I'd like you to just look at from this diagram is that our esophagus is actually behind our trachea, and there are structures in the throat which help to ensure that food doesn't end up going down the wrong tube. And the primary structure for this is called the epiglottis, and we'll talk more about these parts in just a second. The pharynx is made up of three parts. There's the nasopharynx, which serves as the passageway between the nose and throat. And this area of the pharynx is linked to the middle ear via the auditory tube, which we talked about in the special senses chapter. And this part of the pharynx is normally open for breathing, but it must close when we swallow. And the uvula, which is a fleshy tab of tissue that hangs down in the back of the throat, acts as a kind of door between the nose and throat. And this contracts and moves upward to close the passageway when it's touched by solids, such as when we're eating. Then there's the oropharynx, which is the area directly behind the tongue through which food and drink pass through. And this part of the pharynx has a mucous membrane and epithelial lining which are very thick and durable to allow for all the abuse they end up taking when we swallow. And then finally there's the laryngopharynx, which is the last part of the respiratory tract shared by the digestive and respiratory systems. This is an anterior opening which leads to the anterior opening of the laryngopharynx leads to the larynx and the rest of the respiratory system, whereas the posterior opening of the laryngopharynx leads to the esophagus and the digestive system. The larynx serves as a divider between the upper and lower respiratory tracts, and the larynx actually holds the respiratory tract open, guards the lower tract against particle matter, and helps to produce the sounds for speech. And the larynx is actually composed of a total of 9 pieces of cartilage, 3 single piece structures, and 3 paired structures. So that equals 9. And this consists of thyroid cartilage, which is at the front of the larynx. And this is a shield-shaped piece of cartilage that often protrudes from the throat. And in males, testosterone stimulates the growth of this piece of cartilage, such that this is actually what is responsible for the Adam's apple in men. And then the epiglottis is a leaf-like flap of elastic cartilage on the superior part of the larynx. And like I said, this is a piece of cartilage which covers the hole leading to the lungs and prevents food from entering into the respiratory tract. And then the last single piece of cartilage is the cricoid cartilage, which is a complete ring of cartilage that holds the respiratory tract open. And I'm pretty sure this is the only complete ring structure in the body. And then there's the cornicillate cartilages, which hold the epiglottis in position above the glottis and ensure that it doesn't collapse when it doesn't need to. And then finally there's the arytenoid and cuneiform cartilages, and these are the pieces of cartilage are responsible for pulling on the vocal cords, and they allow us to alter pitch. Also within the larynx are 2 pairs of vocal cords, the false vocal cords and the true vocal cords. And both of these are covered by mucous membranes and held in place by elastic ligaments. And they vibrate, or rather the true vocal cords vibrate as air passes through them, and this is what allows us to produce sound. And the tension that we hold on the true vocal cords is what determines pitch, and the vibration determines how loud a sound is. So here you can see all of the cartilaginous parts of the larynx, and in this diagram we have both an anterior and posterior view, so feel free to look at this. Here's the other part of that diagram, which shows where the vocal cords are and what position they take when they've moved apart. And over here on part B, you can see what the view of the vocal cords looks like through a laryngoscope. On to the lower respiratory tract, and the main function of this part of the respiratory system is to move the inhaled air to the respiratory membrane in the lungs. And within this respiratory tract there's a conducting zone, which is the part responsible for conducting air from the atmosphere to the respiratory zone deeper in the body. And this conducting zone includes all the structures of the upper respiratory tract, as well as the trachea, bronchi, bronchioles, and the terminal bronchioles. And then there's the respiratory zone, which is the actual part of the respiratory system where the actual gas exchange takes place. And this zone lies deep within the lungs and includes only the respiratory bronchioles and the alveoli, and I'll tell you what these are in a second. The lower portion of the conducting zone and the respiratory zone are collectively referred to as the bronchial tree. So here's a diagram of the lower respiratory tract, and you can kind of see why it's referred to as a bronchial tree, because it looks like an upside down tree. But anyway, the larynx serves as the divider between the upper and lower respiratory system, and the trachea here is the first tube which leads to the lungs, and this branches off into two primary bronchi which go into the right and left lungs. The trachea is the portion of the respiratory system which connects the larynx to the bronchi, and the trachea is a 12 centimeter long tube which extends from the base of the larynx to the fifth thoracic vertebrae in the chest, and this tube is approximately 2.5 centimeters in diameter. The trachea is composed of muscular walls which are embedded with 16 to 20 C-shaped pieces of hyaline cartilage, and these are oriented towards the back of the throat. These C-ring structures support the trachea so that it does not collapse during breathing, and they also allow for the expansion of the esophagus during swallowing. Now sometimes there may be an obstruction in the trachea, and some sort of intervention might be necessary. So one of these methods is a tracheotomy, which is an actual insertion into the throat to provide a temporary breathing tube so that airflows to the lungs. And this allows us to bypass the larynx if there's some sort of obstruction up in the larynx or in some other part of the respiratory system. And to intubate is to insert a tube through the nose or mouth and push it down through the larynx into the trachea, and this would be done if an individual is having trouble breathing on their own. And then finally, when the carina of the trachea is touched with some sort of object, this triggers a dramatic cough reflex, which would then allow us to move the object out of the respiratory system. And this cough reflex is obviously triggered when any object touches the carina. The trachea splits into the two primary bronchi, and each of these bronchi leads to each lung. The bronchus in the right lung divides into three branches, and the left bronchus divides into two, and these branches that they divide into are called the secondary bronchi. The secondary bronchi themselves each branch out and continue to get sequentially smaller as we get more tubes. And these secondary bronchi lead to the tertiary bronchi, which lead to the bronchioles, which themselves lead to the terminal bronchioles, which lead to the respiratory bronchioles, and then finally the alveoli, which basically look like dried grapes in the lung. As the bronchial tree continues to divide, there are some other changes that occur. The cells of the mucous membrane get smaller. At the start, epithelium is pseudostratified ciliated columnar epithelium. And then once we get to the large bronchioles, this is ciliated columnar epithelium. In the smaller bronchioles, we're at ciliated cuboidal epithelium. And within the terminal bronchioles, we're just that simple columnar epithelium. The composition of the walls of the bronchi and bronchioles also change as the tubes get smaller. So in the smaller tubes, we've gotten to where we have no cartilage, because these tubes can be completely shut down simply by contraction of the smooth muscle in the lungs. Now in asthma and other diseases classified as obstructive respiratory diseases, the smooth muscle can become irritated and tighten, which reduces the tube diameter, which sometimes effectively closes it, and it's here that we would have an asthma attack. And we'll talk more about asthma in the preceding slides, or rather the following slides. The lungs are the key organs of respiration. and these are housed in the thoracic cavity. They are lightweight organs which extend from just above the clavicle or collarbone to the 12th thoracic vertebrae in the chest, and the lungs fill the rib cage. The base of the lungs is the broad portion which sits on a muscle called the diaphragm, which is a muscle which allows us to breathe, and we'll talk more about the diaphragm later on. And though we have two lungs, they're not identical. The right lung is shorter and fatter and has 3 lobes, whereas the left lung is longer and narrower and has 2 lobes. Now, the left lung has a depression or notch for the heart to fit into called the cardiac notch on its medial side. The medial portion of the lungs is called the mediastinal surface, simply because the mediastinum is the central portion of the thoracic cavity. The bronchi, major blood vessels, lymphatic vessels, and nerve supply enter and exit the lung, or each lung, at an area called the hilum. So this diagram is just showing you where the lungs sit within the rib cage. And as you can see, the right lung has 3 lobes and the left lung has 2. Then we also have an inferior view of the lung where we're looking up at it, just so you can see where its placement is in the chest cavity compared to the other organs. And obviously the spinal cord is up towards the top in this diagram or picture, and the lungs are towards the bottom, or rather the sternum is towards the bottom. So within our thoracic cavity we have a structure called the pleura, which wraps around the lungs. And the pleura is a serous membrane which allows for the lungs to expand and contract without having them tear, as they're fairly delicate tissues. And the pleura is actually composed of 2 membranous layers separated by serous fluid. So there's the visceral pleura, or the visceral pleura, which lies against the lungs, the parietal pleura, which lines the walls of the thoracic cavity, and between these 2 pleura we have the pleural cavity, which lies between, or rather, it contains the serous fluid. Now, the tension of the fluid between these 2 membranes is what creates a slight upward pull on the lung tissue, which ensures that the lungs stay inflated. There's also a slight vacuum in this cavity, which also helps. Now, if enough air or blood enters the pleural space, the lung tissue in that area can collapse. And this may happen due to an injury to the thoracic cavity, the thoracic cavity. And this collapsed lung can be caused by pneumothorax, which is air in the pleural space, or hemothorax, which is blood in the pleural space. So in order for the lung to be restored such that it can inflate, the air or blood must be evacuated to restore pleural integrity. Now, pleurisy is when the pleural membranes swell after being inflamed or irritated, and this causes them to rub against each other. This makes breathing difficult and may indeed require anti-inflammatory drugs to combat the inflammation. So here's a picture of a collapsed lung over to your right. It's pretty obvious. And you can see that when these lungs deflate, they really, really deflate. And something's going to have to be done here to reinflate that lung. So now we're at the respiratory zone, where gases are actually exchanged. And within the respiratory zone, there are bronchopulmonary segments, which resemble grapes on a vine. And these originate from a terminal bronchiole, which feeds all the respiratory membranes of each bronchopulmonary segment. One pulmonary arteriole runs to each segment, and one pulmonary venule returns from it. And then we have lobules, which are small groups of respiratory membranes which extend off the terminal bronchiole. These are wrapped in elastic tissue and covered in pulmonary capillaries. The respiratory bronchioles lead to alveolar ducts, which is where oxygen enters the bloodstream and carbon dioxide exits, and this occurs only in these grape-like structures called the alveoli, plural for alveolus. And the alveolus is a cup-shaped membrane at the end of the terminal bronchiole, and it's clustered into an alveolar sac at the end of the terminal bronchiole, which is actually the part which looks like the group of grapes. The walls of the alveolar sac are two squamous epithelial cells, thick. There's one cell at the alveolar wall and one cell in the capillary. And this is because we need an extremely thin membrane to allow gases to diffuse through. And generally, when we're talking about the respiratory system, we need a thin, moist membrane with a large surface area, and this would be the ideal membrane through which we'd want gas exchange to occur. So we need a moist membrane in order for gases to diffuse across the lungs, but unfortunately, moist membranes have a tendency to stick together. So in order to combat this stickiness, we have septal cells scattered throughout the lung which produce a chemical called surfactant. And surfactant is a detergent-like fluid that moistens the alveoli but prevents the walls from sticking together during exhalation. Surfactant also solubilizes oxygen gas to promote its uptake into the lungs. Sometimes premature babies have difficulty breathing because they're not to the point where they can produce surfactant. And also within the lungs we have these alveolar macrophages, or dust cells, and these are immune cells which remove any inhaled particles that might escape the mucus and cilia of the conducting zone. So this just counteracts whatever dust particles might have somehow ended up in the respiratory zone. Here's the anatomy of a bronchopulmonary segment in the lungs. And as you can see, like I said, it looks like a bunch of grapes. And within this pulmonary segment are these little cups that are actually, well, they look like grapes. And it's in the membranes of these grapes, or alveoli, that the actual gas exchange occurs. So here over at your right, it depicts the diffusion of gases across the membrane. So here in this blood vessel right next to the 2-cell thick alveoli membrane, we have a low O2 concentration and a high CO2 concentration. And over here on the other side of the membrane, we have a high O2 concentration and a low CO2 concentration. So the O2 flows into, or rather diffuses into, this blood vessel in the body, and the CO2 going from high concentration to low concentration diffuses out, and we breathe it out when we exhale. And that's essentially how respiration works across a membrane. Section 13.2, air must be moved in and out of the respiratory system. Inhalation and exhalation, or the process by which we take in and release air, are governed by the muscular movements of the thoracic cavity. And another word for inhalation is inspiration, and another word for exhalation is expiration. And that explains some of the corny jokes that the author of this book is telling in the headings of the chapters. But anyway, we'll refer to them as inspiration and expiration in addition to inhalation and exhalation. So inhalation requires muscle contractions, and exhalation requires the muscles to relax. Pulmonary ventilation is the inflow and outflow of air between the atmosphere and the alveoli, and this is dependent upon Boyle's law. which essentially states that the volume of a gas varies inversely with its pressure. So this means as volume goes up, pressure goes down, and vice versa. And here it says the increase in the size of a container of gas without adding gas molecules will increase the volume, of course, because we've increased the size rather. And this means that the pressure in that container must decrease according to how much the volume increases. Like I've said, or at least alluded to anyway, inspiration and expiration are controlled by various muscles within our thoracic and abdominal cavity. So in inspiration, we have this muscle called the diaphragm, which contracts and flattens out and causes the bottom of the thoracic cavity to drop, which increases the size of the thoracic cavity. The intercostal muscles also contract, resulting in the ribs being raised slightly. This allows the lungs to expand as they are connected to the thoracic cavity by the pleura. So essentially the thoracic cavity has increased in volume such that the lungs also increase in volume. And this increase in volume of the lungs causes the pressure to drop, which results in the air moving into the lungs as it moves from the high pressure to the low pressure zone in the lungs. Then in expiration, the same muscles that were contracted relax and the thoracic cavity returns to its original size. This causes the pressure in the lungs to increase, which leads to the air moving out of the respiratory tract as it moves from a high pressure zone to a low pressure zone in the surrounding air. Here's a diagram of how inspiration and expiration work in the body. And on the left portion of this diagram, it's basically just showing all of those muscles contracting such that the thoracic cavity increases in volume, which increases the lungs' volume, so that the air flows into the lungs from an area of higher pressure to an area of lower pressure in the lungs. And just a few of these muscles to remember are the diaphragm, the external and internal intercostals, and also the external and internal obliques. And I'm not going to worry too much about the transversus abdominis and the rectus abdominis. And then over at the right of the membrane, it just shows the air moving in to an area of higher pressure to an area of lower pressure in the lungs in inhalation or inspiration. And then we have the opposite in exhalation or expiration. This diagram shows the pressure changes which occur during pulmonary ventilation. So at number 1, the diaphragm is at rest, and this means that the atmospheric pressure and the alveolar pressure are the same, and that's 760 millimeters of mercury. The intrapleural pressure is 756 millimeters of mercury, so slightly less, excuse me. So when the diaphragm contracts and pulls down such that the thoracic cavity expands in volume, we have the atmospheric pressure at 760 millimeters of mercury, but we have the alveolar pressure at slightly less, and this is 758 millimeters of mercury. And this is enough to let the air move into the lungs as it goes from higher pressure to lower pressure. And then when the diaphragm begins to relax, the pressure, or rather the alveolar pressure, decreases to 762 millimeters of mercury. And this causes the air to move out of the lungs as it goes from this pressure of 762 millimeters of mercury to a pressure of 760 millimeters of mercury. So expiration is essentially a very passive process, as it mainly involves muscular relaxation. However, in forcible expiration, we contract the abdominal muscles, which pushes the abdominal organs backward, upward, and into the diaphragm, which decreases the size of the thoracic cavity and thereby further decreases the air pressure that we would normally see in expiration to an even lower pressure, so that we can force the air out of the lungs. And as mentioned, there's a vacuum between the two layers of pleura. The partial pleura is pulled outward with the expanding walls, while the visceral pleura remains attached to the lungs, and this occurs during expiration. This prevents the collapse of the thin alveoli during expiration or exhalation. The walls of the alveoli spring inward as the air leaves the respiratory tract, but the alveolar walls do not collapse, but instead stick together thanks to this vacuum. And this obviously helps the lungs enlarge and fill with air on the next inhalation, because if the alveolar walls had stuck together, we couldn't really inhale. I'm pretty sure we covered this in the nervous system, but your brainstem is what sets your respiratory resting rate. So your resting rate, or respiratory resting rate, is the number of breaths which you take over a set period of time while at rest. And this is usually in breaths per minute. Your resting rate is determined by the medulla oblongata and pons in the brain stem. So the medulla oblongata causes rhythmic contractions of the diaphragm, or rather leads to the rhythmic contractions of the diaphragm through its controls. This cycle repeats continuously unless overridden by higher brain function. And this would mean that you can essentially choose to hold your breath or not, even though this would lead to you becoming unconscious over a period of time. But once you become unconscious, your brainstem will take over again and you'll start breathing again. The chemoreceptors in the carotid artery, which is in your neck, and aorta sense the levels of CO2 and O2 in the blood. When we're experiencing high CO2 levels, this immediately triggers an increase in the depth and rate of respiration. A 10% increase in CO2 levels doubles the respiratory rate. A large decrease in oxygen level is needed before these receptors, or rather, we need to know what the oxygen level is before the receptors cause the respiratory rate to rise. So essentially, we're saying that oxygen level is more important here than CO2 level. There are several different types of respiratory volumes which are used to describe the different types of breath. So here we just have these volumes listed and defined. Tidal volume, or TV, is the volume of air moved in and out of the lungs during normal breathing, and this is typically 500 milliliters per breath. Then we have inspiratory reserve volume, or IRV, which is the maximum volume of air that can be forcibly inhaled. Compare this to expiratory reserve volume, or ERV, which is the maximum volume of air that can be forcibly exhaled. Now, vital capacity, or VC, is the measure of the total volume of air your lungs can inhale and exhale in one huge breath. So another way to describe this would be that it's the maximum amount of air that your lungs can move in one respiratory cycle. And we can determine vital capacity using the following equation. Vital capacity equals tidal volume plus inspiratory reserve volume plus expiratory reserve volume. And then finally we have residual volume, or RV, which is the amount of air that remains in the lungs after forced expiration. So this is the amount of air that always remains in the lung no matter how much you might try to force the air out. And this is typically between 1100 and 1200 milliliters. And this is actually useful because this volume helps to hold the alveoli open and fills the anatomical dead spaces that occur when we moved all of this air out of our lungs. This chart just shows the amount of air involved with each type of respiratory volume. And we're just going to really focus on the maximum numbers in this. I originally thought that the larger number was for the male and the smaller one was for the female, but honestly have my doubts, so we'll just focus on the larger number. So tidal volume is 500 milliliters, inspiratory reserve volume is 3,100 milliliters, expiratory reserve volume is 1,200 milliliters, residual volume is 1,200 milliliters, and the vital capacity is 480 milliliters. And we'll not really focus on the rest of these except for maybe total lung capacity, which is about 6,000 milliliters, because I feel that those are enough of respiratory volumes for you to learn about. Section 13.3, External respiration brings supplies for internal respiration. Now, external respiration is the exchange of gases between the air in the alveoli and the blood in the respiratory capillaries, and this obviously takes place in the lungs, whereas internal respiration is the exchange of gases between body cells and blood in the systemic capillaries. So this happens within, or rather between, the blood vessels and the body cells in the body. External respiration secures oxygen and disposes of carbon dioxide. Partial pressure is the percentage of total gas pressure exerted by a single gas in, well, it says the mixture, but it's kind of just any mixture, really. Now, Dalton's law states that the total pressure of a mixture of gases is equal or equivalent to the sum of the partial pressures of each individual gas in the mixture, which simply means we can add together the partial pressures of each type of gas together and come up with the total pressure of a mixture of gases. So in the atmosphere, the air is made up of 78.6% nitrogen, 20.9% oxygen, and 0.04% carbon dioxide gas by volume. And these percentages are equal to the percent pressure that these gases exert. So if we knew the pressure of each of these gases, we could add them together and get a total air pressure of 760 millimeters of mercury. And like I said, we only need to determine the partial pressures of each gas and add them together to get this number. Now, Henry's law states that the amount of gas diffusing into a liquid is directly proportional to the pressure of that gas. Dalton's and Henry's laws both indicate that gases move from higher pressure to lower pressure, at least when they're used together anyway. Oxygen will diffuse from the air in the alveoli into the blood, and carbon dioxide will diffuse from the blood to the alveoli. And we'll look at this in more detail in the next slide. So this diagram displays the diffusion of carbon dioxide and oxygen in the respiratory system. And up at the top we can see all the numbers of the partial pressures of each type of gas in the atmosphere, and here we can use, or rather apply, Dalton's law and add all of these partial pressures together and get our 760 millimeters of mercury. And then over here at the bottom, it's more showing Henry's law. And here it says the inhaled air has these two partial pressures of gases. We have O2 at 159 and CO2 at 0.3. Whereas in the alveoli, we have oxygen at 104 and CO2 at 40. And this essentially means that in order for oxygen to get into the blood, it goes from higher pressure to lower pressure because the oxygen pressure in the blood is 100, whereas it's 104 in the alveoli. And here the CO2 partial pressure doesn't really matter because we don't really want CO2 to come into the bloodstream because we don't really want to transport to the body tissues. So it just stays at 40. And here in the systemic tissue cells, we have oxygen at less than 40 such that it can diffuse into the cell, and CO2 at 45 because we really, or more than 45, because we really do not want that CO2 to get in that cell because we can't really use it. And then here, when the gases diffuse out, we have the CO2 at 45 outside in the veins, and as it flows from higher pressure to lower pressure, it goes from more than 45 to less than 45 quite easily. And here, when it gets to the lungs, CO2 is at 45, so it diffuses out of the blood, and we can release it back into the air. And if I ever ask you any questions about Dalton's or Henry's law on the test, I'm going to first give you a worksheet you can go over, and if I don't give you a worksheet, I'm pretty sure I probably won't put anything on it in the test. Internal respiration supplies oxygen to the cells and removes the gaseous waste. So in the capillaries of systemic circulation, which occurs within the body, oxygen and carbon dioxide diffuse in opposite directions, as is what happens with external respiration, because we want oxygen to be going in and CO2 to be going out, and vice versa. So in external respiration, oxygen enters the tissues and carbon dioxide diffuses out based on partial pressure, so still high pressure to low pressure. The partial pressure of oxygen in the capillary beds of the systemic circuit is approximately 95 millimeters of mercury, whereas the partial pressure of oxygen in most tissues is about 40 millimeters of mercury. So it obviously diffuses into those tissues as it goes from high pressure to low pressure. Compare this to cellular respiration, which produces carbon dioxide, and this is where we're getting our carbon dioxide from. The partial pressure of carbon dioxide in the tissues is about 45 millimeters of mercury, while in the capillary beds has a carbon dioxide partial pressure of 40, so it moves into the capillary beds, and this is essentially the same thing I just told you with the diagram. And keep in mind that the small gradient is still enough to cause carbon dioxide to diffuse from the cells to the blood in internal respiration. This diagram is essentially just a summation of both external and internal respiration, and it actually shows quite a bit less than that other diagram I showed you. So here on the upper right of this diagram, you can see oxygen leaving the lungs by way of the blood to the left atrium of the heart, and then it leaves the heart and is transported to the body cells where it diffuses into the cells, and then CO2 diffuses out of the cells, is transported to the right atrium, and then it's transported to the lungs so it can be removed from the blood, and then we take in more oxygen at that point also. And when we're transporting O2, we have 1.5% of this dissolved in the plasma, and 98% of this is connected to the hemoglobin as we would want it. And then on the transport of CO2, 7% of it is in dissolved plasma, 23% of it occurs as CO2 bound to hemoglobin, and yes, it does bind hemoglobin, and 70% is there as ionic bicarbonate. Section 13.4, Transport of Oxygen and Carbon Dioxide, requires hemoglobin and plasma. So just as a small review, respiration involves not only the structures of the respiratory system, but also the structures and proper functioning of the cardiovascular system. And we'll just break it down like this. The respiratory system moves the gases into and out of the body. Oxygen moves from the air to the lungs, where it diffuses into the capillaries of the lungs, and carbon dioxide moves from the tissues to the blood and out via the lungs, which is kind of getting old, I understand, but I just have to say it. The cardiovascular system transports gases within the body, and this determines how these gases are carried through the cardiovascular system between the two capillary beds. So we've talked about it in the previous chapter, but hemoglobin transports oxygen. Hemoglobin picks up oxygen through a bond between the oxygen molecule and the iron atom or ion of the heme molecule contained within the hemoglobin. Now normally hemoglobin has a high affinity for oxygen, under some circumstances, but will release it under other conditions. And it has to release it because the body tissues need this oxygen at some point. And this affinity of hemoglobin for oxygen, and when I say affinity, we're talking about hemoglobin's ability to latch on to oxygen. And this is illustrated by the oxygen hemoglobin dissociation curve, and we're going to look at that in a second. Understand that the bond between oxygen and hemoglobin is reversible because it is necessary. Oxygen binds hemoglobin when the partial pressure of oxygen is high, pH is high, and temperature is low. And like I've said before, exercise generates heat due to the muscles working. The pH is lowered because we've begun to produce lactic acid because we're performing fermentation rather than cell respiration because we're probably getting low on oxygen. And this causes the hemoglobin to release oxygen, and this is what we need it to do because the body tissues and the muscles need this oxygen. These graphs show the effects of pH and temperature on hemoglobin binding, or hemoglobin's ability to bind oxygen. And here in black, we just have the hemoglobin affinity for oxygen in normal conditions. So here at left, the normal condition is a blood pH of 7.4. So at a high pH, or a basic pH, or rather a basic blood pH of 7.6, we see that hemoglobin's ability to bind oxygen has gone up, and this is shown by the blue line. Whereas in the red line, we have a low blood pH, or an acidic blood pH of 7.2, and as you can see, we have a decreased affinity for oxygen in these conditions. And then here at right, the same thing with the black line. This is at normal blood temperature, though, instead of pH. So when we decrease blood temperature, the ability of hemoglobin to bind oxygen increases compared to a high blood temperature, which is where the affinity for oxygen decreases. And as I said, we don't have a graph for partial pressure, but just remember that when partial pressure goes up, hemoglobin affinity for oxygen goes up, and when partial pressure goes down, the hemoglobin affinity for oxygen goes down. Now that we've beaten oxygen transport to death, we're going to focus on the transport of carbon dioxide, which occurs through at least three mechanisms. Hemoglobin conveys about 23% of the total carbon dioxide through the bloodstream. And when CO2 binds to hemoglobin, this forms what is known as carbaminohemoglobin, or HB/CO2. 7% of the carbon dioxide is carried in the blood as dissolved CO2 gas, and the remaining 70% of the total carbon dioxide moves as bicarbonate ions in the plasma. So here's how this works. Carbon dioxide and water combine to form carbonic acid inside erythrocytes, or red blood cells. And this reaction is aided by an enzyme called carbonic anhydrase. The carbonic acid then dissociates into a hydrogen ion and a bicarbonate ion. This hydrogen ion is picked up by the hemoglobin, which forms a reduced hemoglobin. And by the way, whenever something picks up a hydrogen, we say that it's reduced. Bicarbonate ion is exchanged for a chloride ion, and this chloride ion is what's entering the erythrocyte. The large transport of chloride ions into the red blood cell, or erythrocyte, is called the chloride shift, which is an exchange reaction that actually requires no ATP because it merely switches the positions of ions, or anions in this case. This then allows for the bicarbonate ion in the plasma to serve as a buffer, which helps to maintain blood pH. And by the way, when oxygen is bound to hemoglobin, this is called oxyhemoglobin, or HB/O2. That's a pretty telling name. This diagram just shows CO2 transport at both the or rather in internal respiration and external respiration. And external respiration is at the top and internal respiration is at the bottom. And you can pretty much just see the summation of the reaction I just talked about. And we'll not really go too far into this, just try to remember that information from the last slide. Section 13.5, Respiratory health is critical to survival. So here for the rest of the chapter, we're just going to talk about some common diseases, disorders, and other conditions involved with respiratory health. First, we're going to start with sinusitis, which is an inflammation or swelling of the sinuses. And just remember that itis always means something is inflamed or swollen. And the sinuses are cavities in the skull, and don't freak out about these cavities in your head because they simply work to reduce the weight of the head. And these sinuses are lined with a mucous membrane. A common cold or flu or other virus can swell the nasal membranes here. This causes histamines to be released, and this leads to an increase in mucus production as the membrane tries to rid the body of the virus or other pathogen. The membrane swells, and this causes the opening in the sinuses to shut sometimes, and this prevents mucus produced in the sinuses from draining, and this causes it to build up pressure within the sinuses. Now, there are two different types of sinusitis. There's acute sinusitis, and this is usually caused by the common cold, and as it's called acute, it goes away on its own within 2 or 3 weeks. This is probably the most common type of sinusitis. And then we have chronic sinusitis, which is more severe, and the causes of this type of sinusitis are less clear. However, we can use antibiotics, inhalant steroids, or oral steroids to help cure this problem. This diagram shows where the sinuses are located in the skull and also how they're shaped, I suppose. And we have anterior and lateral views. And there really isn't much to say here other than you can clearly see where all the sinuses are in this diagram. Continuing with diseases and illnesses related to the respiratory system, here we have otitis media, notice the itis, and this is an ear infection. It's an inflammation of the middle ear, which causes the middle ear to fill with fluid, which descends the eardrum. And to descend means that the eardrum is stretched, and this can cause severe pain. Sometimes the eardrum can rupture as the bacteria within the trapped fluid multiply, and we're only saying that otitis media is related to the respiratory system simply because the auditory tube is connected to the upper respiratory system. And this illness can be treated with antibiotics, and it generally occurs in small children simply because the auditory tube in small children is almost horizontal, such that fluids in the mouth can easily travel to the inner ear and become filled with bacteria, which causes the infection. Now we're going to talk about more serious respiratory conditions, and these are divided into 2 types of diseases, obstructive and restrictive. And obstructive diseases are serious but are often sporadic. So one type of obstructive disease is bronchitis, which is an inflammation of the mucous membrane lining the bronchi. The membrane here swells and the lumen, or the hollow tube part of the bronchiole, constricts. The infected bronchioles then produce more mucus, which can block air passages. The most common symptom of bronchitis is a deep and often painful cough. And there are 2 types of bronchitis, acute and chronic. Acute bronchitis is typically caused by viruses and occasionally bacteria. And this type of bronchitis has these additional symptoms, which include shortness of breath, tightness of the chest, and a general feeling of illness often occupy the cough. And then we have chronic bronchitis, which is most often caused by smoking. It's actually responsible for a smoker's cough, and this can last from months to years, depending on the severity of the reaction to smoke and the duration of the smoking habit. Treatment for this type of bronchitis includes rest, plenty of fluids, and over-the-counter medicine, or I should say this is treatment for both kinds of bronchitis. If the cough persists, an inhalant bronchodilator may be prescribed, and this bronchodilator relaxes the smooth muscle of the bronchi, leading to the opening of the constricted tubes, which helps to clear out the mucus. Another type of obstructive pulmonary disease is asthma, and this can be life-threatening because individuals are subject to asthma attacks. Asthma is also typically genetically linked. Anyway, during an asthma attack, the smooth muscle of the bronchi constrict, mucus production increases, and the bronchi swell, and this interferes with the passage of air. This causes breathing to grow laborious, and wheezing becomes common during expiration. An asthma attack can be triggered by exercise, viral infection, or inhalation of cold air, or an allergen, a substance that causes an allergic reaction, or by high levels of ozone in the air. Asthma may result from an overactive immune system. Typically, inhalers containing bronchodilator drugs are used to quickly open the airways. Corticosteroids may also be inhaled to reduce the number and severity of asthma attacks. However, asthma still kills up to 5,000 people every year in the United States, which sounds kind of high. Now we're going to talk about restrictive pulmonary diseases, and these can cause permanent lung damage. These are characterized by a reduced lung volume, and like I said, they may damage or destroy specifically the terminal and respiratory bronchioles. And we're going to focus on the three most common, mostly, and these are pneumonia, tuberculosis, and lung cancer. There's also pulmonary fibrosis, which is a condition where we have an increase in destructive collagen that also makes the lungs less elastic. And this usually results from occupational exposure to silicone, asbestos, or other similar irritants. Okay, I was unintentionally dishonest in the last slide. We're going to talk about the three most common obstructive respiratory diseases, but we're also going to talk about 2 or 3 more. And the first of these is chronic obstructive pulmonary disease, or COPD, which is actually 2 diseases. And if you watch TV, you've seen a couple of drugs being sold to cure this. And this is actually 2 diseases, like I said, chronic bronchitis and emphysema. We've already covered chronic bronchitis, so let's look at emphysema. Emphysema is caused when pollutant or cigarette smoke damages the alveoli, or rather the alveoli, forming holes in the alveoli that cannot be repaired. The lung structures then become fibrotic or filled with fibers like collagen and stiff, which reduces their elasticity and makes exhalation much more difficult. The disease is gradual and starts with a shortness of breath and continues to get worse with age. Smoking causes more than 80% of such cases of, I believe, emphysema. It might be for both, or for COPD. Emphysema can also be genetic. However, emphysema may be treated with antibiotics to kill the bacteria in the alveoli, or anti-inflammatories and bronchodilators to help open respiratory airways. However, advanced cases may require the use of supplemental oxygen or a lung transplant. And when we say supplemental oxygen, we're talking about carrying around a tank of oxygen. In the U.S., the death rate from COPD has doubled in the last 30 years to an estimated 120,000 annually, which just seems like way too many. So here we have a diagram which shows emphysema and COPD. So over here at the left we see a normal alveoli compared to a damaged, shriveled up alveoli. And over here at the right you can see this picture. I'm not sure if it's an x-ray or MRI or CAT scan or what, but here you can see what are presumably really messed up lungs. Kind of rather hard to tell actually, but the book says they are. Now we're going to talk about some of the more common respiratory complications and conditions, which can be either bacteria caused a cancer or genetically inherited or related. And the first of these we're going to talk about is pneumonia, which is a general term for buildup of fluid in the lung, often as a response to bacterial or viral infection. In most cases of pneumonia are caused by a bacteria called Streptococcus pneumoniae. And in pneumonia, the delicate membranes in the alveoli become inflamed. This results in the secretion of fluid in an attempt to eradicate whatever pathogens causing the inflammation. The fluid, however, inhibits gas exchange across the membrane, because how can you have gas exchange when your lungs are filled with fluid? So the symptoms of pneumonia include a productive cough, lethargy, fever, chills, and a shortness of breath. Treatment actually depends on the cause of the fluid buildup, and if it's bacterial, we can obviously treat it with antibiotics. I'm not sure if there's many antivirals available or not. However, it usually can be treated, but can also be fatal, especially in those individuals with weak immunity because of another serious condition or illness. Tuberculosis is another common restrictive lung or pulmonary disease, and this disease is caused by infection by Mycobacterium tuberculosis, and I always end up thinking that this is a type of fungi because myco refers to mold or fungi, but rest assured it's a bacteria. And this is a tiny bacterium which can pass from person to person in airborne droplets generated by a sneeze or cough. If the immune system can combat the disease, scar tissue may form at the focus or where the tissue is affected. If the infection, however, is not eliminated, the bacteria can enter the lymphatic system and infect just about any organ. In addition to this, the bacterium can also infect the lungs and then become dormant for years and then eventually reappear in the lungs without warning. Symptoms of tuberculosis include productive and often bloody cough, fever, chills, and shortness of breath, in addition to weight loss and night sweats. Tuberculosis can usually be diagnosed with a chest x-ray. However, previous exposure can be detected by a simple skin test, which is mandatory for children entering United States public schools. Antibiotics have reduced its incidence in industrialized nations, but it is on the rise again because of the appearance of antibiotic-resistant strains, and we'll talk about how we can possibly not contribute to producing antibiotic-resistant bacteria when we cover immunity. Here's what a positive tuberculosis test result looks like, and I'm assuming this is a recolored x-ray. Anyway, I guess the infection is what looks like basically these little clumps of broccoli in the lungs. Now we're going to talk about what I would call the end-all of restrictive pulmonary diseases, lung cancer, which causes 1/3 of all cancer deaths. And lung cancer can affect the bronchi or the alveoli, and results in hindrance of airflow and prevents gas exchange. 90% of all lung cancer patients in the U.S. are current or former smokers. Lung cancer takes years to develop, but the risk increases with each year of smoking. Quitting smoking reduces this risk, even for long-term smokers. So this is why it's a good idea to avoid smoking and exposure to environmental carcinogens such as asbestos, silicone, coal dust, and radon gas. It also puts into perspective how important it would be to quit smoking if you are smoking, and if you can quit, I would say you need to do that, though I understand it can be difficult. So our last restrictive respiratory disease is cystic fibrosis, which is actually a genetic disorder. And cystic fibrosis, or CV, results from a defective gene which controls the consistency of the mucus in the lungs. And those with this mutated gene produce a thick, sticky mucus rather than the typical thin fluid mucus that helps or aids in gas diffusion or gas exchange. And this thick mucus produced by those with cystic fibrosis traps bacteria and slows airflow through the bronchial tree, and it can also block the pancreas and bile duct because it's produced there too. Treatment for the lung obstruction includes physical therapy to dislodge the mucus and new drugs that may make the mucus more fluid. And this is a really good candidate for gene therapy because we're just dealing with one affected gene, which is always makes something a good candidate for gene therapy. There are approximately 30,000 people in the United States currently living with cystic fibrosis, and 1,000 are diagnosed each year. I would say we probably lose nearly that many each year. And typically the average lifespan for someone with cystic fibrosis is around 25 years old, so their lifespans are pretty short. Anyway, this concludes Chapter 13 on the respiratory system. I believe we're covering the digestive system and nutrition next, and that's going to be the first time we cover 2 chapters at once, so be prepared for a pretty long set of lecture slides.